Good afternoon, dear colleagues. We are ready to start our discussion, and before we begin, I would like to attract your attention to the safety precautions. Our company pays a lot of attention to safety, so please be sure that you notice the doors here. We are also equipped with fire alarms. Today, I hope there will be no emergency, but if you hear any alarm, please stand up and walk through the door to your right or to your left, following the indicators to the evacuation doors. Please also take care on the staircase. Do not use the elevators, and get together outside the building. In case you experience any health issues, please address those issues to the organizers of the events, and we will call the ambulance. Thank you very much for the attention, and at this I would like to begin our session. This session will be devoted to the modern technologies of people who work especially in remote areas and in remote companies, not only onshore but also in the sea, using modern technology and telemedicine in particular. The relevance of this discussion is obvious for the whole world, and here we can mention three different factors. First of all is the strategic development of our country, including the healthcare system, not only in the cities but also in remote areas, such as villages and industrial companies. Also the lack of industrial and human resources, especially in remote areas, as well as the need to increase the quality of medical services with the use of medical technologies that are also predicted for in the federal projects. Today we will discuss two models. The first model that is based on the federal program, and the model that is based on outsourcing the services. Today we will listen to experts and their experience on integration of certain telemedicine for industrial companies that work in remote areas. Being a moderator of this section, I would like to remind you about the time limits. The talks should last not more than 15 minutes, and we will also provide 5 minutes for questions and answers. The questions and answers session will begin after the presentation. During your presentations, I will remind you about the time, and if needed, I will give you additional time, 1 minute, to finalize your presentation. And with this, I would like to invite our first speaker, the expert from Norway, Ketil Torgersen, the Chief Facilitator, and his colleague Kate Wald, also facilitator at Stavanger Acute Medicine Foundation for Education and Research. You're welcome.
You can access and read the article using the QR code on this slide. You will also find the QR code on our last slide. I think I was properly introduced. I also have my colleague doing the co-presentation. She is Kate Wald. She's a senior facilitator at our center in Stavanger. She's a graduated nurse and also has a master's degree in pre-hospital care from the University in Stavanger. SAFER is a foundation, a collaboration between Stavanger University Hospital, the University of Stavanger, and Lærdal Medical. This project was initiated in 2018. Equinor wanted to investigate whether they could improve the overall quality of the on-the-job training activities for their onshore emergency medical teams. The concept was designed based on repeated short, frequent simulation-based training sessions. The training was designed to be a supplement to regular simulation-based training at the simulation center. These offshore emergency medical teams consists of 1 medic and 5 to 6 first aiders and a consulting doctor onshore. The project was funded by Equinor, and technical innovations were made by Lærdal Medical. Safer developed the pedagogical model and facilitated all the training sessions. The aim of the article was to investigate, 1, whether telesimulation to an offshore oil platform was feasible. 2, if the participants think it could be a valuable supplement to regular training at the sim center every second year. 3, how the participants compared the telesimulation to regular sim center training. And 4, how they rated the learning outcomes from these telesimulation compared to sim center training. In a pedagogical context, the aim was to develop a tool that could increase effect of existing training programs. The telesimulation model enables low-dose, high-frequency training. Evidence support that this could increase learning outcomes and change clinical behavior. It will also allow us to design distributed practice training. So please, Kate, unmute and take over.
All the simulation sessions were facilitated by a senior facilitator at SAFER, and they were conducted a total of 10 simulations throughout the pilot testing period. We will now show you a short video showing how this worked. I am very sorry for the Norwegian language, but you will see a team of 1 nurse and 3 first aiders taking care of a patient in chest pain. They will assess the patient, give oxygen, take ECG, and send it to the doctor. They will give morphine and thrombolysis. And in the end, they will have a debrief where the participants sit in the installation offshore. The physician is in her office in Bergen, and the facilitator is at SAFER in Stavanger.
So if the organizers could now please show the video. That was the agreement that they were to show the video. Please play it. Okay, that will obviously not happen, so I think we need to just proceed in our presentation, Kit.
Yes. We will now, this is the model of how this technology works, and as you can see, it's quite complicated. A standard scenario was used for all the simulations, and you can see the descriptions here. There was a patient presenting chest pain caused by a STEMI or a myocardial infarction. Aim was for ECG to be interpreted within 10 minutes and thrombolysis given within 20 minutes, as in Equinor's protocol. 1 hour was set aside to the simulation, and the debrief structure was according to EU SIM methodology, description, analysis, and application phase. Short time after each of the every simulation, we send an evaluation to each of the total 30 participants, and we get an answer from 23 of them. They answered their profession, their simulation-based training experience, and so on. Next slide. As you can see, there were 8 nurses, 12 first aiders, and 3 physicians answering. And they reported on their prior experience from simulation-based training. As you can see, 52% were first aiders, and only 2 of them had no prior experience of simulation-based training. Yeah, and from the participants' point of view, telesimulation was rated just as good as or better than center simulation-based training in 87% of the evaluation. As you can see, we got quite high scores. We asked them to rate their experience from 1 to 5. It looks like the level of difficulty is okay, not too easy, not too hard. And the participants found a high level of realism in the scenario. That probably had to do with doing the simulation in their own environment, using their own equipment and calling the doctor just as they would do in a real life situation. As you can see, the participants rated the simulation experience very high and found this to be a good way of training. Next slide. And we had some limitations. There was a small number of participants, and we don't know how the training affected self-efficacy since this was not investigated, and we only had the results for Kirkpatrick level 1 perception, and there were only 1 training session per team, and there were no room for improvements. And we didn't use a validated evaluation form, so we don't know whether they answer what we wanted them to do, but we think they did. The offshore nurses found this to be a good way of training, also because they didn't know what was coming. They usually design all the training themselves. Kjetil?
Thank you. So even though this oil company did not implement the telesimulation at its 35 sites, we believe that the experiences from this project might have impact in smaller companies, other industries, and in international projects, since the methodology enables experts to support simulation-based training remotely. More research is needed to investigate the learning outcomes and transferability to other industries and also to low and mid-income countries. We are currently doing several projects where we are testing out the remote or telesimulation concepts. One of them is using Microsoft HoloLens. This is done in a collaboration with the tech company Bouvet. We are also conducting training and faculty development programs in Africa and in India, where this technology is part of our concepts. So we believe that this is something that is there is a need for this in the future, and that the value of the experiences from this project is transferable. So I think there was 5 minutes allocated for questions. So please ask questions if you have them.
Thank you very much. That was a very interesting project. I also have experience in sea work, and I can really evaluate the relevance. Thank you also very much for your presentation, not on the topic. Indeed, we have one question to you. The question is, are there alternative ways to organize telemodeling and telesimulation that does not use internet or with low internet connection?
because the internet connectivity, especially in Africa, is an issue for us. Right now, there are no alternative ways of doing this. You need at least a 4G connection to allow for the bandwidth needed. But we know that the 5G networks are coming, and hopefully when those are ready, we have tested enough of these concepts so that we can scale up and roll them out with no problems. But for now, the internet connectivity and bandwidth is an issue in certain places.
Нет, ну спасибо большое. Еще раз доклад. Уважаемые...
Dear colleagues, let's switch to another speaker. Next speaker is Dr. Talik Gailan, marine medicine and diving physician, head of the Moroccan Marine Medicine Society, Morocco. Dr. Tariq, you're welcome. You're welcome. We are listening to your talk.
So much.
Доктор Тарик, мы вас слушаем. Начинайте.
Yes. Good morning, everyone. I'm very happy to be with you, to share with you our experience in Morocco, and to speak about our opportunities in the maritime, what we hope about telemedicine in maritime sector here in Morocco. So we will speak about telemedicine in maritime sector in Morocco, what's opportunities. I'm sorry, I don't know if you hear me very good. I think my voice is not good. Just because yesterday we had elections in Morocco, all elections for the municipality, for the parliament, and for the regions. Regions are like states in Russia. So we finish around 4 or 5 morning. We had not much time for sleeping, so for this my voice is not good. Please forgive me. So just for introduction, to see that here in Morocco we have a very important maritime coast with the marine sector, which provide nearly 140,000 seamen, with 120,000 in the fishing sector and 10,000 in the merchant marine, and then 10,000 in the port. And we signed the MLC convention. We know that since January 22, the ILO MLC has required all flag sector to provide seafarers with the medical care, as possible equivalent to the care they would receive ashore, and to ensure that medical advice by radio or satellite communication to ship at sea is reliable at hour of the day or night. As such, every ILO signatory nations like Morocco is bound to have a pre-arranged system for wireless medical advice available to ships of all nationalities, raw to clock and free of charge, also known as telemedicine assistance services. This network ensures communication through marine radio, email, telephone, or fax, and in more recent times, via real-time video calls. The legal framework here in Morocco is now defined. We have our law for exercise of medicine, the law for exercise of medicine in Morocco, the law 131/30, relating to the practice of medicine, introduced this principle of telemedicine in his section in the chapter 3. So as telemedicine and its global outlines and implements decree has defined the types of telemedicine in Morocco. So we have teleconsultation, tele-expertise, remote monitoring, remote assistance, and the medical response. What is our marine sector in Morocco? We have merchant marine and fishing marine. We have just to see that the fishing sector is very important in Morocco, more important than merchant marine. Even if recently in the last 10 years, with many merchants or the merchant marine take every day more importance, but since 20 or 30 years ago, it was the fishing sector which was the very important, and it participates with 2 till 3 of the GPD in Morocco. So now telemedicine has become reality in Morocco with the legal basis of this practice. We spoke about the law who organized the practice of medicine and practice of telemedicine, but also there was a special decree or a special only for telemedicine relating to the practice of telemedicine in Morocco was adopted by the government recently. So according to the Article 10 of this decree, the relations between physicians practicing in the private sector and non-profit health establishments, private health establishments, or establishments similar to clinics which organize a telemedicine activity must make the difference, subject to an arrangement which specifies the conditions for exercising said activity. So with this, there was also improving of learning and formation in this field, and the first promotion of students with a degree in telemedicine began in 2020. There was the university or the medical school of Casablanca who began this learning for doctors, and now we have our first promotion ready to practice telemedicine. What other opportunity? There was creation of specific or scientific society or scientific organization for telemedicine, Moroccan Society for Telemedicine. It was created in 2018 in Rabat, but is national organization. The aim of this organization is promote telemedicine in Morocco and make this practice easy and known by the majority of doctors. What other opportunity? There was also creation of telemedicine centers in Morocco with the help and the support of this scientific organization I spoke about, which is the Moroccan Society for Telemedicine, which will properly equip pilot seats located in rural and isolated areas for the realization of teleconsultations act covering both the general medicine and specialties identified as priority. Ultimately, a national plan will be developed and implemented. So it was just an experience first to help persons in these isolated regions to receive normal medical care, but also it was experience to see if telemedicine will encounter some problems to generalize this experience around all Morocco. So there was just a question if the answer, I'm sure it will be yes, if COVID-19 was an opportunity for telemedicine. Yes, it was, and I think not only in Morocco, but I think in all the world with this pandemic, there was many practice trying to making this distanciation between patients and practitioners to preserve the health of practitioners and also of patients sometimes, because the transmission can be from both directions. So there was development of teleconsultation and remote medicine during the pandemic, the COVID-19 pandemic, and increasingly frequent use of remote communication technology. So it's true that, for example, we in maritime medicine, we begin, for example, consultation via WhatsApp. So it was a communication technology. This is not telemedicine, but it's remote medicine. And these practice open the brain for practitioners and also for population that there is another mode of practice of medicine, and these practice can be efficient if we can respect some conditions. And also our epidemiologic profile is compatible with a telemedicine implementation. Here we have some Moroccan epidemiologic studies among fishermen, which show an increase and very important rate of, for example, infections, 32%, especially sexually transmitted infections. Some dermatosis, we have something around 44%, especially with fungal infections, and some respiratory diseases, which is classic with fishermen, and also MSD, musculoskeletal diseases, 39%. Well, these infections show that telemedicine can be a help and a support for fishermen, but also for other seafarer, for other for merchant in the merchant marine. So it can help. So, not what is the situation? We have a basic a basis for legal practice of telemedicine. We have first experiences for telemedicine practice in the rural sections. We have a very important demand of telemedicine in the maritime sector, and also the pandemic 19 show us that we are able to practice this, to make this practice easy in our daily practice. And recently, the Kumhavat is a special organization who works in the eastern part of Africa and try to promote the fisheries and the sector of fisheries in the eastern countries of Africa. Morocco is a member of this organization, and during their last Congress, which was in Morocco, the Congress was about maritime health and maritime medicine. They speak about all things about fishermen, not only health, but this time it was especially dedicated for health promotion of fishermen. And one of the very important conclusions and recommendation of this Congress was helping African countries to start telemedicine in their practice. The first time we spoke about this, and maybe because we were with some poor countries and speaking about this, they told us, no, we think that telemedicine is something like it's not a necessity now in African countries. It's a practice like thalassoterapia or something like this. There was their vision of things, especially because we were with politicians, with deciders, and not with doctors. But when we spoke about telemedicine, or we spoke about the benefits of telemedicine, when we spoke about the actual situation, if the benefits, all of them was take this topic with very serious desire and would like to have also their platform for telemedicine. So the idea is that all opportunities we have are now. There was also an experience here in Morocco with French telemedicine centers, the same of Toulouse, but the experience was not good, only because doctors in France spoke French language and our Moroccan fishermen speak Moroccan dialect or Arabic. So the communication was very, very bad. For this, we take all our arrangement to begin with telemedicine next 2 years. First in the maritime sector and the merchant sector, to be later generalized to fisheries sector. I thank you
that's
so
terrific.
much, and also I'm sorry for the quality of my voice. Really, I sleep not much hour. Thank you so much.
This is доктор Тарик. Морская медицина действительно очень серьезная тема, и наша компания также очень заинтересована.
Interesting and hot point issue, and our company is also interested in the development of this issue. And we have one question. The question is the following: do you have some significant difficulty which marine medical workers face in Morocco? Which is the most significant difficulty, you would say?
To speak about a health statute, sure, the MSD, musculoskeletal disease, are the first pathology here in Morocco. The problem is, I spoke in the last Congress, we have like 2 medicines for safaris in Morocco. We have very organized medicine in the merchants marine, and these problems of MSD are well taken in account with the doctors, but we have another medicine for fishermen, which is we have not much doctor for fishermen. So problems like this are very important and not quite taken in account with doctors. There is a very important problem in the health field about seafarers or fishermen in Morocco, MSD.
Коллеги из зала, если есть вопросы, прошу.
So thank you very much, and our colleagues from the conference room, if you have any questions, you're welcome. My name is Alexander. I would repeat, Dr. Tariq. My name is Alexander. Our company is dealing with a platform on Talk that is a personal account of a patient and a doctor and administrative personnel of a clinic. And I would like you to share experience. How is telemedicine arranged in your country? Which software do you use? For example, how you keep records during consultations? Because what I heard is that you have a possibility to communicate via telephone, fax, email, or chat. So which opportunities you have? How is it arranged? Which software you use and so on? Just as an example, can you please describe?
Thank you so much for the question. It's something like a technical question. Well, telemedicine centers we have, I spoke about, which are in rural and very isolated areas in Morocco, are now working with the Wi-Fi, with wireless. So the software is they work with wireless with high depth, but this is the only technology we have now. I told you that we spoke during the pandemic 19 with other types of telemedicine like WhatsApp and phone conversation, but it was not organized. It was just only a necessity. But the only centers existing now in Morocco are in, I told you, in these isolated areas, and they are working with wireless, with Wi-Fi.
Thank you for your answer. Dr. Tariq, if we don't have any more questions, then we switch to another speaker.
Dear colleagues, I would like to attract your attention to the next speaker, Dr. Wu Quoc Binh, President of Dr. Binh Teleclinic and the Director General of Vietnam Telehealth Resource Center, Doctor of Medical Sciences. The report on the solution to the gap between the telehealth care and in-person practices. Dr. Binh, you are welcome.
Can you see my screen? Hello? Can you see my screen? My presentation? Hello? Hello?
Yes, Dr. Binh, we can see.
Hello? Hello? Okay, thank you very much. Thank you very much. First arrow from Hanoi, Vietnam, very, very far from two homes. I would like to say thank you very much to me to attend at this, I think it's a very interesting international conference. Добрый день. In the 15 minutes, let me share our experiences, our solution to the gap between telehealth care and in-person practice. The first arrow, I would like to make some clear the differences, including advantage and disadvantage between telehealth care and in-person healthcare. And the second one, I would like to share some our learning from the pandemic in Vietnam regarding to demand for telehealth care during COVID-19. We share some solution we have done. At the end is some suggestions. The differences between telehealth care and in-person healthcare. There are a lot of things, but let me go into focusing on the chronic disease management and high quality care, especially for the remote areas. And how can you improve the outcome by chronic disease management, and what the telehealthcare can done if they cannot do physical and lab examination, and about legal medical documentation. Why I would like to go to focusing to the chronic disease management, because the chronic disease now is main causes of death and disability for the people in the world. And the number of deaths because chronic disease from time to time increasing. In 2030, 3/4 total number of deaths in the world. And 4 diseases are the main causes of death is cardiovascular, cancer, COPD, and diabetes mellitus. And chronic disease is significantly economic burden with 2,970 billion US dollar per year, and especially for the in middle and low income countries. And why I am going to make it clear for the high quality for medical professional service, because we know already a few years ago, the medical errors still the first most common causes of death in the US. And the other one, the question is, for example, for chronic disease management, for in-person healthcare or classical healthcare is rendered, but telehealthcare can improving or not. The same for the high quality for remote areas can improving with telehealthcare, and the improved outcome by chronic disease management could be better than in-person healthcare. And the other 2 points I am going to make clear is next slide. Our lesson learned from Ho Chi Minh City, one example. From last 10 years, from 2010 to 2020, you can see here the number of visits increasing from time to time, from year to year. But 2020 is the first time from last 10 years, the number of visits to medical facility dropped very strongly, about 5 million visits. And in comparison between the medical point, private polyclinic, private hospital, city hospital, and in general, we found that the reduction rate from medical point and private polyclinic very strong decreasing until 90% in comparison between 2019 and 2020. In the other hospital, city hospital, district hospital, ministerial hospital, range from 16 to 21. It's similar to the Brazil hospital, is 10, and the United States hospital from 16 to 20. From this situation, raising up the question, how can you take care of the people that cannot coming to the hospital, even medical point and private polyclinic? So now I will share some of our solution. The first one, the technology development helped a lot using personal health devices through the personal air network, Bluetooth, and we have integrating healthcare enterprise, IHE, and wide area network, and we have health record network, telehealth service center. At the end, we have electronic health record and personal health record to remote monitoring for the patient portal, doctor talking to doctors, virtual appointment, personal health application, and personal health record. Setting up call center 24 hours to 7 and medical mobile teams. There are audio videos, phone calls, virtual consulting, store forward analyzing data, remote physiology monitoring, and virtual check-in. To improve, to control, to improving the quality of the medical staff practice, we digital convert all of medical guideline international, the updates to the computer. So we can control, improving, and we have required our medical staff following the international standard. E-signature, and our patient can take their mobile phone, iPad to show the prescription by pharmacology to get their medication. And we long-term management, because we have long-term data, and we can management, the best management for the chronic disease. From the big data, we can analyze this for prophylaxis, the bad situation, including cancer, early disease cancer, and prophylax chronic disease. Our mobile application can consultation for the patient, testing, treatment, remote emergency medical assistant for chronic disease, occupation disease, and even for the COVID-19 patient. After they come out from the hospital and they have to improve, continues at home. And our mobile application got one of the best award 2021 for excellent product solution of Vietnam IT and software industry in the field of the health. There are a lot of social media activities with Vietnam Assembly TV channel, radio, social network, YouTube, with over 100 live serial program about chronic disease and epidemic management. There are mobile device developing for blood pressure, skin camera, thermometer, glucose, ECG, ENT, spirometer, pulse oximeter, stethoscope. And last night we developed the mental health counseling call center, and counseling call center for the teenage 24/7. From this one, at the end, let me share some suggestions. The new technology development can close the gap between telehealthcare and in-person healthcare, especially for the chronic disease management, very important thing, and remote area healthcare, as well as improve the quality requirement for the healthcare professionals, thus meet international standard. You can see here after our solution, the gap between telehealthcare and in-person care close together. Even with telehealthcare, we can improve a much better in cooperation with person healthcare. The second suggestion, the application platform, healthcare service provider and government need to work together closely to bring the many benefits of telehealth to the public. All people, especially those in high-risk groups, should learn more about and take advantage of telehealth technology for better protection of their health and that of their loved ones. Thank you very much for your attention. Большое спасибо для внимания. Большое спасибо.
Уверен, что ваш
Thank you very much. I'm absolutely sure that your vast experience can be scaled up and used by providers in telemedicine. We have one technical question to you. What, in your opinion, is a disadvantage, some software or some solution, technical solution that fails to meet the needs of telemedicine? Do you have any bad experience with technical solutions?
Now is we from time to time we have to integrate a lot of mobile device to our system. This one especially for the ECG, electrocardiograph for real-time ECG is one difficulties. But we seem to try to make the best real-time electrocardiograph. The second one is, I think the best advantage for telemedicine is chronic disease management. Because for the people with chronic disease management, they cannot come to the clinic every day, every week, normally monthly. For example, for diabetes mellitus, some people very busy and they have very high blood glucose. And to make the best drugs regimen dose for them, you have to continuously data. If you have just cut up the data, they cannot keep them the best dose of medication. We have a lot of experience with the people. With telemedicine, we given a lot of chronic disease, complicated disease people, happy man, happy day, happy life. That is the best the best way, the best advantage from telemedicine.
Dr. Bin, thank you very much. Again, I would like to now ask our audience, do you have any questions? Thank you very much, Dr. Bin, for your participation. We are happy to learn from your experience. We were happy to see you today, and we hope to continue cooperation. Thank you.
Dear colleagues, we go on. I would like to represent the following speaker. It is Ivan Tutrin, the founder and research director of MedNord Technica, Doctor of Medical Science, Professor of the Higher Attestation Commission, and the topic is the role of monitoring hemostatic potential for industrial workers recovered from COVID-19. So you are welcome. So dear moderator, dear colleagues, the purpose of my presentation is that to present information about availability of new medical technology which provide us with the possibility to estimate all sensoric risks and allostatic reactions of organism which appear. And the possibility of this technology allows to work in two key trends of the 21st century. It is trend point of care test and telemedicine. So the pandemic of COVID-19 made the line between in healthcare and on the global scales between the possibility to cope and impossibility to cope in some particular cases. So there appeared some new cases, absolutely new ones, depending and related to COVID-19. And today everyone is involved into the solution of this issue, starting from the nursery personnel up to doctors, but everything related to post-COVID treatment is presents some black area nowadays, because everything which we see in the internet related to post-COVID syndrome is very vague and unclear, and latent period is indicated as 12 months today, and it's not a limit yet, it's obvious. And clinical syndromes in post-COVID period the range is very wide. And if we add some particular cases and difficulties we have in order to cope post-COVID syndrome. So some clinical issues are not solved yet and new ones appear, but everything which depends, which is related to pathogenesis is not a problem. You can see on the slide the most important ones which I highlight. And everything which is related to cardiovascular problems. So all these problems is transformed to post-COVID. And if several months back coronavirus infection was treated as a lungs infection, today it's obvious and it is acknowledged by all specialists all around the world that it is cardiovascular problem, cardiovascular pathology. And in this case, we always come to Virchow's triad and everything which relates to these problems is based on the wide known algorithm of different thrombotic disorders. And there are some risk scales acknowledged all over the world, and thrombophilic disorders related to some chronic diseases also in patients, and questions of prophylactics and treatment come to selection of some proper groups of medications. It doesn't matter whether we treat or we just perform prophylactical measures. And I would like to highlight again that we see absolutely different symptoms of post-thrombotic syndromes. There are 5 key questions to answer. Which medication, which dose, which intermittency, how long should it be taken, and how to control it. And if we add existing polyprognosy, and we can see which medications and how difficult it is to choose and for a doctor and to answer all these questions. And it is obvious that existing methods which are used to control anti-thrombotic therapy are not efficient at all. I like this slide very much because currently we resemble those scientists which are black-eyed, and their result is very bad because the elephant is supposed to press them all, and all our medicine nowadays with all those protocols for post-COVID treatment, they resemble this slide. They are 2 clotting tests and D-dimer. Based on these 2 factors, it is suggested to base therapy, taking into account those clinical syndromes which we have. Currently, there is a group of tests, and they push clotting tests apart, which are carried out in citrate plasma, and everyone is acquainted with blood tests, how it is taken, transported, and so on. Information value of this test will be presented later on. The doctor's dissertation of Einstein is as a basis of this test. And I like this slide also, which says no problem can be solved from the same level of consciousness that we created it. But not only due to this quotation, but also due to the tests which he did. Today, we have a new technology which allows us to estimate all cholestatic reactions which appear at every stage. This technology is based on the analysis of a key marker of the systems of inborn immunity reactions, key humor systems related to allostatic reactions. Please pay attention to the right side of the slide. All clotting tests which are used today, probably they're not all, but about 95% of them are based on the analysis of citrated blood. It is what is used for all tests. So please pay attention to what we analyze. 0.3% of the clot of the blood is what we analyze. And based on that percentage, with the error which is related to pre-analytical factors, we try to set therapy and those disorders which appear in the organism, the multiple number of them, whatever we face. And if you pay attention to the proposed technology, you can see here that we analyze not only hemostatic potential, but also inborn immunity, interferon complement, all heme-independent factors, and 0.5 milliliters of blood allow us to get information. Next slide will show the different possibilities with different clinical cases. It doesn't worth talking about these parameters. They are widely represented in the literature, but all these reference points, they are depend on humor system factors. Primarily, a doctor having information about functional system in analyzed population, all these changes, they are related to population variability. So we can talk about hypercoagulation changes of parameters which are responsible for all those functional systems which I mentioned. Hypercoagulation allows us to monitor all therapies, taking into account also medications which are prescribed. So the modern possibilities in NeuroNet technology allowed us to also to estimate the main triggers, thrombocytes of all functions, because they participate in all functions of the organism, which we whatever can imagine. So this new technology allows us to have information about all functions, a complete complex of data about functional state of this or that system which is to be corrected or requires some preventive use. So here we can see the polymorphism, some particular thrombophilia, because all of us in that on this level are thrombophilic, and the new technology allows us to get information about some particular patient in some particular period of time. And this slide represents an approach of specialists, and it was an agreed one in order to an algorithm how to manage coagulation during COVID-19. Based on these parameters, the doctor shall take a decision about diagnosis and monitoring of antithrombotic therapy. So this is an example. Two patients in our hospital. One of them is 67 years old and another one is 60, and the parameters we can see are nearly the similar ones, and based on international protocols they should be treated in a similar way. But in this case, in the first one, we can see a little bit different situation with inborn immunity and DDU and MA and Clexane recommendation leads to normalization of coagulation. But in the second case, we see nearly the same situation, and it was estimated and it was assessed according to all currently existing protocols, international ones. And this patient also receives Clexane, for example, but we see a lethal death here in this case. So phenotype is very important to be estimated in such cases for preventive treatment. And so phenotypes of hemostatic potential are represented on this slide, and which are identified in post-COVID patients. And there is another vivid example. So there is a very severe alopecia and elastomia, and after 7 days of treatment, the parameters were normalized, and phenotype of hemostatic potential is recovered. Another slide shows the same. So there is some particular pre-treatment before vaccination, then vaccination and reaction to vaccination. And the answer why thrombosis appear after vaccination in some patients is very clear based on this slide. And as a conclusion, I would like to show to you a very complicated, as you can think, schedule, but it is very clear. It shows the reaction of allostatic conditions to stresses. So here you can see different components which react to stresses, and allostatic reactions look like that. And endothelial dysfunction correction and development of this treatment will allow us to meet the needs for prophylactic, for preventive treatment and for diagnosis in those patients which have high risks of thrombosis disorders, all the cardiovascular disorders in post-COVID patients. And I think that not in the following 10 years and more, we will face the same issue, and it will help us a lot. Thank you for your attention. Yes, thank you very much. Today, when pandemic is still very acute, this question is a hot point. There is one question related to the possibility of this monitoring at remote facilities. Now we are dealing with this issue, and in cooperation with Mr. Antipov, and we are trying to solve this issue. We have a scale NL estimate. We've done a stratification of risk groups, and we are dealing with these risk groups, and we are developing correction schemes. Endothelial dysfunction in Norway, for example, is corrugated due to some populational features. It is, for example, correlated with some different angioprotectors. The one which we use, for example, the medications being produced from cedar or from some other coniferous trees is very efficient in Siberia or Kazakhstan, for example. In those patients, we work a lot with medical workers nowadays. They come to us, and some doctors also conduct studies, and for example, they take different oils, krill oils, for example, due to flavonoids and antioxidants, provides them with a possibility to speed twice the recovering time in Krasnodar region or in Khabarovsk region, and the effects differ. So it is, for example, we can say that red wine, Georgian one, has a hyperprotectin efficiency also, for example, just as an example. Thank you very much. After the program will be developed, I think that it will be widely used. My name is Yana. I'm cardiovascular doctor. We have another question. Yes. So, did you conduct tests related to an efficiency of new oral anticoagulants? Yes, we conduct such tests a lot in conjunction with different centers. We analyzed Begatron, Liquis, and Vasildev, which is in all protocols indicated as a medication which doesn't have anticoagulation efficiency. And we also made a comparative analysis of sulforphorin with single and double anti-aggregate therapy. And even in post-COVID treatment, so Vasildev is a medication, to my mind, which deserves being selected in our Siberian Rivaroxaban, in our Siberian population. Also is highly efficient because it sufficiently lasts for 24 hours. The dosing was 10, and it was in conjunction with anticoagulants. So there should be anti-aggregates, anticoagulants with angioprotectors and with biologically active additives also.
Remote location, let's say. If you're still here with us, you can address your question to our speaker.
You translate me.
We can hear you. I still hear.
I don't listen.
Я думаю, что коллега отключился, да, поэтому, наверное, вопрос.
So there seems to be no more questions, and it's not literary. If you have any questions, you are welcome to ask them in our chat, and we will address these questions to the speakers anyway, if you have them. Thank you very much, and we come to the next speaker.
Let me introduce Daniil Starostin, the Deputy Director of the National Resuscitation Council and the instructor of the AlphaMed Training Center, with his report on the ultrasound diagnostics of emergency conditions and its importance for remote healthcare. Okay, thank you. Good afternoon, dear colleagues. I would like, first of all, to express my gratitude for the opportunity to participate in this conference. It's a great honor and a great pleasure to talk today. You can read the name of my report on the first slide. I would like to give you a prescription for remote medicine, and I'm deeply sure that some of the technologies that are widely used already nowadays at the territory of our country are already used in the whole world, and they can also be included into remote medicine and can be used on a wider scale. I would like now to show the relevance of such technology, and I hope you will be interested. And I hope that you will keep thinking about this idea for the future development to ensure sustainability. So why do we need ultrasound? And I don't want to tease you, and from the very beginning explain you all the main elements which in my opinion are the most important in using ultrasound in remote facilities. Please note that because it's a mobile device, ultrasound devices can be used in remote areas in order to filter injured and ill people. This device on its own is mobile. It can be used in any conditions. It can be taken with you to absolutely any situation. You can indeed use it in telemedicine, online, to diagnose a patient, because you can also use it quickly and conveniently. You can also use it to diagnose not only your patient for the first time, but also manage people with serious illnesses, severe illnesses. You probably know that there are some critical conditions that we sometimes see in our patients in remote areas. And of course, we sometimes also think about the need to evacuate patients, and we need to really understand the resources. So if, for example, we have this situation and we have a problem with blood circulation, and the need arises for the resuscitation of our patients, we can also use ultrasound to diagnose such conditions. For example, it can help us before the situation as well as after the situation. This has an official certification. There is a regulation, legal basis in the federal government. So the order which provides the standard for the doctor who works in anesthesiology and resuscitation. In 2018, we also developed a professional standard for this type of specialist. And since then, we have a particular duty which says that the doctor should not only possess, but also be able to use the ultrasound device in the professional practice. So this underlines the need for high-quality ultrasound practice. This is also true not only for the anesthesiologists, but also for the ambulance doctors. It's part of the regulation. So I'm going to list now only the medical professions which appear quite often. So the anesthesiologists, ambulance doctors, and cardiologists who also consult as well as in remote areas. They also have 2 points in their professional standard, which says that they need to know, they should know the use of ultrasound diagnostics. As for the main job, ultrasound indeed does not have a unique sensitivity and the specificity that can be used in diagnostics, but what deserves attention is the detection of free liquid when injuries appear inside the body. Then the sensitivity can be as high as 100%, and which allows really quick diagnosis of the situation. I would like also to say this, that this investigation, when we, for instance, need to diagnose the whole patient, does not take a lot of time. The examination takes about 3 minutes. When you know how to use the device and when the patient is prepared, this time is sufficient to diagnose and plan further treatment and decide whether you need to evacuate the patient immediately or this is not necessary. When we talk about the classical protocol called FAST, you can read it on the slide. It includes the whole examination of the pelvis, lungs, pericardial cavity, and so on. We can diagnose all the points that you can see in the slide to make sure and detect the free liquid in such points. Altogether, this examination does not take more than only 3 minutes. Another relevant issue is the amount of free liquid. There are certain formulas that are used to calculate them. These are experimental data, and there are, as you can see, formulas that are used for quick diagnostics. And this is quite efficient in order to make the decisions whether we need to make any surgical interventions. So can we monitor the patient for a longer period of time? Do we need to evacuate the patient immediately, and so on? There is an interesting project and paper that was devoted to the use of lung ultrasound and chest radiography and the comparison. And the time of diagnosis using the ultrasound was about 3 times less than the diagnosis with the radiography. As you can see, in remote areas, X-ray is not very commonly used, and ultrasound device can be used as, let's say, a laptop from almost from your table. When we talk about the problems with the blood circulation, we can also use ultrasound. We can even do it using only 1 point. It is sufficient to understand whether we have any cardiac activity and what is the reason for the disruption of the blood circulation. So following the modern recommendations, you can see 3 different schemes. The one on the right with green blocks is made by the European Council, made in 2015. And on your left, an updated version from 2021, an updated version from the European Resuscitation Council. So please pay attention that the ultrasound examination is included in both. And what are the problems that we can solve when we have a problem with blood circulation? We can exclude hypovolemia and hypokalemia, for instance. We can also diagnose the pneumothorax of a patient. Of course, this takes a longer period of time because we also need to assess the rhythm. But if we have an ultrasound device, we can ensure continuous monitoring during the whole period of time when we work with the patient. Talking about the lung investigation, there is a blue protocol that describes different types of examination of the lungs. And the modern trend here is to use new devices for coronavirus, COVID situations, and here you can see an example of a research that was done before the pandemic, and you can see the statistical data which compares ultrasound and X-rays. And here, for instance, it's important that the specificity and sensitivity is quite high, especially when we talk about pneumonias. A different research was related to the use of ultrasound and computer tomography of the lungs. Here you can see the comparison of the volume that was infected coming from different methodologies. So you can see some artifacts, the B lines, the so-called B lines, in one of the parts of the lungs. On the left, you can also see a certain increase of the edema, which is not a specific characteristic, but can also help to diagnose the situation and plan the treatment quickly. We need to understand that ultrasound is not a solution for every situation. I do not try to convince you that we can use ultrasound to treat everyone. I'm just trying to say that ultrasound can be of great use in many medical aspects. And of course, talking about the modern trends, you probably noticed that almost every speaker talks about the COVID situation. Of course, it's important because we faced some difficulties during the pandemic periods. Here we had also problem at the first stage when we had to sort the people with the COVID infection, and ultrasound can be used at this stage when we have a great flow of patients, and ultrasound is also included into the methodology to diagnose people. It still underlines that ultrasound is not the main diagnostic methodology, but because of its mobility and the opportunity to use this methodology quickly, the use of ultrasound was supported and played a great role. I would like to thank the organizers in the end of my talk and repeat that ultrasound has been leading the medical technology in the whole world for a long time. I hope that we can work with new technology. The future is already here, and we have to live in this future already now. Thank you very much for your attention. Daniel, thank you very much for your report, and I would like to add to your presentation that the FAST protocol that you mentioned, it was included in LTS. I studied it in the Central Hospital Fujairah, and a big discussion was there about the ultrasound as a diagnostic methodology. There is a different course, also a great course, just for your information, anesthesia, trauma and critical care. This is a training course for doctors who has already studied ETLS. So if you would like to continue, we can discuss it. And the question to you is also about the FAST protocol. ETLS is a protocol for the medical doctors. How about the paramedics? Can they also use this diagnostic tool and use it in their professional practice? Legal issues nowadays are critical. And of course, everyone asks what I can do, what I cannot do, and what are the consequences. So that is why I believe this is a very important question. I would like to say here that when we developed when this algorithm was developed, I'm talking about the FAST algorithm, then it was launched and applied in the United States, and this also is true about the ETLS. It was relevant for all types of specialists, medical specialists, medical doctors, paramedics, a medical nurse, doesn't matter. So any person, any member of the medical team should be able to use the ultrasound device in order to help the patient. Talking about the Russian Federation, we cannot make a conclusion when you work as a paramedic, because you're not the doctor officially. In order to diagnose, paramedics cannot diagnose, are not allowed to. Of course, they do not use the word diagnosis. They do not use the word conclusion. They perform what is called an ultrasound monitoring. So ultrasound can be considered as a diagnostic tool for monitoring. So you just change the word, and you can use the device For example, you can say that it's not diagnosed, but there is an opinion as a doctor, as a paramedic. I believe that the surgeon needs to be consulted and so on. So it's just a matter of how you formulate the conclusion. Just call it monitoring instead of conclusion. So there is no problem here. It can be done by a medical doctor or a paramedic or a different type of a medical specialist. Well, thank you very much. There's a lot of feedback. Do we have any more questions? My question is about the economic feasibility. So ultrasound device is quite expensive. How often can we use it? And of course, we can train people use ultrasound devices. But if we use it only once a year, then what is the profit? Is it economic? Is it valid from the point of view of economics? And the question is, of course, let's say you train a person to use an ultrasound device, but if you do it only once a year, you lose skills. You cannot do something with high quality if you do it very rarely. Yes, thank you very much for your question. My answer would include two aspects. First of all, talking from the position of a doctor, I'm sure that every life is valuable, and it does not matter how often we use something, even if it's once a year. In my opinion, it is important from the point of view of modern technology. From the economic point of view, which I believe is the most important aspect in your answer, I cannot give you statistical data about how often, for instance, people in remote areas can need ultrasound diagnostics. I can only say that trauma and different injuries for people in remote areas, they happen quite often, and they have big consequences. And we often face the need for the evacuation of such patients. So my main message was that we can use ultrasound as a modern tool to diagnose and plan evacuation of such patients. Talking about training, there is no doubt that this is the skill that needs to be trained and retrained, supported, maintained. There is no alternative answer here. Of course, medical specialists need to practice and maybe even sometimes invite patients for this particular reason, to learn and practice the use of ultrasound devices. Thank you. And we have one more question from the audience. This is a very important topic. I'm the one who will buy and use, or will not buy and use, the ultrasound devices. And I would like to say that cost is crucial. In the Russian Federation, so far, unfortunately, we have to think about the economic aspects. I absolutely agree that every life is valuable, but unfortunately, in Russia, the life of one person, of an individual person, is really cheap. So we have to assess the risks. We have to assess how far people are, when and how patients can be evacuated, and how quickly. So talking about the previous question, ETLS, in the version that was developed 10 years ago, did not work properly. It was only an additional mechanism. But my question now is whether we indeed need to diagnose so accurately. We sometimes only need to diagnose, for instance, blood problems, but we do not need to understand the reason for it. Because we also have to take into account the climate and conditions, like whether it's winter, for instance. We have such remote areas like Zabaikalia, for instance, and they have very good transport connection. And then in such situation, in those conditions, I don't need an ultrasound device. And the administration, management of hospitals also do not see the need to buy an ultrasound device. But in some other situations, when there is no connection, like no such devices, but then we immediately should raise the issue of training the medical specialists, because if you have a device and you cannot use it, then why do we have it? As an alternative, we evacuate the patient to a medical center where we have an expert who can quickly diagnose. Thank you for your comments. I believe we should provide for some flexibility, and we can continue this discussion taking into account all the possible aspects. And I can see that we have one more question. To continue the previous discussion, I would like to say that talking about the remote areas, medical specialists monitor some standard situations, hemodynamics, for instance, blood situation. Can you mention one or two emergency situations that do not affect hemodynamics when ultrasound diagnostics can be a key to make the final decision? Yes, I can mention now, I would say it's any situation which only starts to develop in its early stage, before it becomes critical. For example, I'm talking here about the primary pneumothorax. In this situation, the patient can only say that he or she has some pain in the chest, but the blood conditions would still be the same. Such a patient can continue working, but the problem with lungs will develop. And this can produce severe damage to the lungs and to the vessels. At the next stage, the patient would say that he or she has problems with breathing, and then we would prevent further development of the disease if we use an ultrasound monitoring and diagnostics. And in addition, I would like to add that I'm not selling you anything. I'm a doctor, medical doctor, and it's important that we save human lives. Absolutely, but I still would like to continue the discussion. I'm not buying anything from you. I'm talking about the diagnostics that is used for particular reasons. I really need to understand this. So my next question is, what is the probability I'm not talking about any legal issues. Let's say I'm talking about a paramedic or a medical doctor after a short training course, which is different from internship or primary medical education. What is the probability that they can diagnose early pneumothorax? What should be the level of qualification of such specialists? A specialist who is not a specialist of ultrasound, let's say an ambulance doctor or anesthesiologist or somebody like this. You know, I would like to receive some feedback from you. Here there are specialists who never saw ultrasound sensors, who never faced training, never had training on ultrasound. but they had training in the Center for Corporate Medicine in the amount of 8 hours. During those 8 hours, we only teach the skills and the knowledge that are included in the field and fast protocols according to the legislation. So that the training lasts 8 hours, and after that, a specialist can use an ultrasound device to diagnose a patient with high accuracy. So I'd like to give the floor to Vladislav to explain this experience. Dear colleagues, I would like to attract your attention to the situation that we now have a discussion. I want to mention that we do not have the 6th report, and that's why we have some time for this discussion. Do we have a speaker? So then we have only 2 minutes to finalize this discussion. And Vlad, thank you very much for inviting me. Thank you very much for this vivid discussion. I'm a paramedic, and I have been trained by Daniil about 3 months ago. And it's true that for the first time in my life, I used an ultrasound sensor. I worked in a cardio team and in cardiac resuscitation. And when I worked in those teams, we didn't have an ultrasound sensor in our car. And I would like to thank the organizers of the training. That was really greatly organized, and it was very efficient for specialists like me. We received a lot of information, and I'm sure that if now I have an ultrasound sensor, I can diagnose tension pneumothorax or tamponade or a hollow vein. I can diagnose the volume of hypovolemia or the amount of free liquid in different cavities. Besides, as a paramedic, this device can be used by me to decompress tension pneumothorax using the ultrasound device to monitor the situation. And I would like to address my first comment, the next comment to my colleague. I want to make sure that I do not worsen the situation and I do not harm the vessels, because with ultrasound, I can monitor what I'm doing. It's really pity that here we talk about money, but we cannot avoid it. Unfortunately, we have to think about them.
So it really works and it needs being used. We have been talking about butterfly system also, which allows through mobile phone, Android. Even if you make a screenshot, and even if I doubt something, I can send it to my colleagues and they will help me. So yes, you can always refer the rest to your colleagues if you have any issues. So thank you. I was too fast to say that we don't have the last speaker, and I would like to represent him. It is Vladimir Molokotin, Director of Business Development, Quasar Ltd. And his topic is the use of automated checkup devices to manage the risks of cardiovascular diseases at the industrial facilities. Vladimir, you are welcome. Good afternoon. Do you hear me? Yes? I would like to welcome you all, and there is a week of industrial labor health safety in Sochi, the conference which is being held now here, and I would like to tell you about our approach and about the experience which we have in the area of management of cardiovascular diseases at remote facilities. I will start my presentation now. Do you hear my presentation? Yes. I will briefly describe our company. We are a resident of Skolkovo site, and for several years we have been developing an electronic medical checkup systems starting from the year 2014. We have been working with these industrial companies, for petroleum companies and transportation companies in all spheres where a clear view is required when some risky operations are being performed in the spheres where different cars are being operated and heavy traffic trucks are being operated. We have been developing different projects related to informational part, software, integration with some other systems, medical information systems. All our equipment is licensed and is used by our customers on legal basis. Our equipment is represented as follows. It allows for 1 minute to measure different parameters such as sobriety, presence of intoxication, tidiness, and so on. And for 1 minute, we very quickly estimate the main parameters of the state of our personnel and take a decision whether we can or can't provide an access to operate to facilities to this or that person. So I would like to show to you what we are doing with those databases which is formed in our system. When on a daily basis our personnel comes through medical checkup, data come from every person, and from the point of view of cardiovascular diseases, we are based on those medical treatment bases which are widely accepted. And those enterprises who implement our system, they treat it as a kind of a permit parameter or permit system, whether to give a permit to that or this person or not. And if this or that person doesn't parse our system, then he or she may go to face-to-face to a doctor, and then they further decide whether they allow push a button, some button, and allow this person to come to his working place or not. But we consider this approach as incorrect, because inside this software, inside this terminal, there should be a systematic approach how we should treat this risky group of people. There are some special mechanisms being developed, and they allow to manage such cases in corporate healthcare system. For example, we have a risky group of personnel, and in this group we apply those mechanisms. We have a medical company which serves as operator in our system. It may be a company outsourced or some internal company, medical company, and we provide them with tools, and they apply these tools to work to treat this risky group of people, of personnel. So temperature, blood pressure, and all primary parameters are very quickly measured in personnel with our system. There is also a mobile version, and now I come to this slide where a factory sectoral doctor scope of work is presented. he may acquire some operative data in his room. He also gets statistics all over the factory, all around the structure of the enterprise. And the task of the factory sectoral doctor, being a kind of an analyst, to take a decision what they should do with this or that worker. The mechanisms which we provide, they mean that the risky group person should come through a very thorough medical examination to understand where this high blood pressure comes from, for example, or something else. And when he comes from the factory sectoral doctor, probably they should take a decision about the change of his title, his job, if he deals with that or this risky group of risky functions, whether he can drive people or he can work with C category driving license or D category driving license and so on, in order to minimize risks, whether to work with passengers or which is less risky. So to minimize casualties also if he drives in something, let's say, or something like that. So factory sectoral doctor has different dashboards. He can see figures and he can analyze and undertake different activities for medical checkups. He can prescribe also treatment and medications, and to control whether he undertakes, whether he receives these medications or not, or correction is required of treatment. Everything is provided. I will show to you in such mode, So as you can see, he can see a number of people in the group of risk. Hypertension, for example, risky group. All tools are provided here. We provide only a mechanism, but then doctor should take a statistics, and based on that statistics he should undertake some activities. But there are some reference points which help him to operate. On this slide you can see one of our company's clients that integrated our system. They have drivers. In August last year they implemented about 20 terminals at health points. Yellow columns, this is a number of employees which passed through this medical examination, automated one. So about 4,000 people you can see pass on a monthly basis. And blue columns show those patients who were revealed, at least due to some parameters, for example blood pressure or something else. And here the mechanism was triggered when a person comes into the risky group. Then he comes to factory sectoral doctor. He receives a special recommendation to go through additional examination. He receives treatment, and then based on that graph you can see that starting from the 6th month there was a steady trend which shows a reduction of those personnel with an increased blood pressure. So first the risk coefficient was 8.7, and at the end you can see this coefficient being only 1.4. So they reduced this risky group by 4 times, and they obviously reduced also industrial risks of casualties and injuries which could have happened but they didn't. And this approach also provides us with motivation corridor, let's say, for employees to take care of your own health and take those medications which were prescribed. And very often we receive a feedback from our clients that a person, for example, comes in a year and they say thank you that there is such a system which helped us to review such a problem with my health and allowed us to correct it and to provide a preventive treatment, and it was very well implemented. I would like to say that people, when they go through such a process, they feel in a different way. For example, if his or her blood pressure was very high before and he was very tidy going to work, but after this treatment he feels better and they receive high quality treatment, which means that labor length period also increases, and people have, from the point of view of behavior and labor safety, labor safety, they treat it better. And more consciousness we can see also in our personnel. So I'm sorry to say that we have only 1.5 minutes. So now let's come to some conclusions, how data in our system can be used in our complex medical checkups management systems. We have a great experience in dealing with different medical systems, integration with medical systems, and we integrate our system with a system which is already integrated in medical enterprises. There are daily states which are monitored with our software, and we review some cases. For example, we can see the history that one person had 180 blood pressure, for example, and we can start dealing with that case. And this data go to the Ministry of Healthcare. The project has been initiated, and the Ministry of Healthcare is ready to donate, to allot money to those people who are in those risky groups in order to purchase medications, because we can say that, for example, 1,000 rubles should be spent monthly for some preventive measures to correct this or that state, and the Ministry of Healthcare can participate in this program and they are ready to allot money for that initiative. So generally that's it, and thank you for the time. I'm glad to answer your questions. Thank you very much. I think that a lot of our colleagues don't know about their system, but also they use it. And I also have such an experience, and Mr. Sidikh, my colleague, also has experience. Frankly speaking, of course, there are a lot of advantages. There are some minor disadvantages as well, or minor difficulties, but we have been dealing with my colleague, and he said that for the recent year there were a lot of improvements, and those minor difficulties, they were solved somehow. I will read the question from the chat. So the pre-trip medical examination records management is clear, but which is the ESMA data record management? So how the data are being kept, and which legislative document regulates it? So data is stored for 3 years, and this period can be adjusted. So data related to pulse or blood pressure, if I need historical data for more than 3 years, it's also available. We also keep it. From the point of view of the record keeping, the log is electronic, and our doctors work in the system. From the point of view of the protection of this data, we base on the federal law number 152 So there are different parameters for logs being used inside the company and outside the company. The parameters are different, but still we base on this federal law. In large companies, we develop a separate regulative document based on 152 federal law, and we take a solution whether we need some technical requirements for additional safety provisions. It depends on how they personally qualify their network, whether it is safe or not. It's not a problem, actually. We provide such a consultancy service also to our clients. There is another question. Thank you for your report. I think that you are well aware that according to the definition of the Healthcare Association, there are a lot of factors of their health, and now you have been talking about some physical parameters being monitored. And do you have some developments or thoughts how to monitor psychological state of personnel who work at some remote facilities in order to reveal some early states in psychological or psychosomatic states? Today, we have been developing psychophysiological testing methods, not psychological, but psychophysiological ones. There is a new norm for workers, and there is a law background for that, the federal law number 749, and there are different parameters which needs being controlled, and also cardiovascular parameters have been controlled. Some mechanisms we are starting to implement, and we are testing this solution. There is an order 835. Based on that, you can go through medical checkup on our terminal, and also there is a pre-trip medical examination for workers of Rosatom company for nuclear atomic stations. And I think that these methods are also applicable to some other personnel for remote facilities. And this system can work not only within the framework of the terminal. You need only a laptop, and you can connect to our internet cloud, and checkups can be split into periodical and pre-trip or pre-shift checkups. So, Vladimir, thank you very much for your report and for the answers. Do you have any other questions? There is another one from the audience. Thank you for your report. Did you have an integration with the medical information system dialogue? We had such a project in Sibur company. It was said that we need to integrate with Medialog. The system has been launched now. There are 19 facilities, and more than half have been launched. But during the implementation of this program, the client decided to use another data system. But there is nothing difficult to integrate with that system as well. If we talk about MIS system, then we integrated it with North Nickel and with some other companies. So from the technical point of view, it is possible. They viewed our data log, and they said that it is possible to integrate it with their data log as well. We have been discussing a lot of integration projects with a number of companies, and we have been doing it rather successfully. We have such an experience, and the system itself is ready to work in different protocols to receive and to transfer data. As we view it, this is the value of this system, because we don't measure something locally and provide it to some paramedics, but it is a complex of solutions. Do you perform integration yourselves, or you involve some other contractors? It is a collaboration with our clients. First, we send our system to view, and they check it. If something is missing, then we improve it, but those projects which have been initiated, the developers from our client side, they see our documentation and they don't have any questions. They say that in North Nickel we are now on the test stage. We provided API required, and we haven't got any questions from them. They receive all data they need. Thank you. Once again, thank you for your participation. And we wish you good luck. And we say hello to Sochi from Tomsk. Goodbye. So, dear colleagues and participants of our section, I would like to say thank you again to the speakers for their very interesting reports, and what is important, that they followed the timeline. And to the conclusion we may have is that telemedicine projects are very important to be implemented for perspective and efficient model of healthcare system at remote facilities, at industrial facilities, in different agricultural facilities, and what is important for us, of course, industrial areas. And also we can use a complex of up-to-date technologies and patient-oriented telemedicine and systems of medical evacuation. And I would like to thank you to all the participants, and good luck. Thank you.